So next is urinary retention V48. For your FY1 calls just as you're about to scrub for an appendectomy to inform you that he has seen a 65-year-old man referred from A&E department with acute urinary retention. What do you want to ascertain over the phone? The most important information is how much is the volume, less than 800 acute retention, more than 800 chronic retention, any evidence of sepsis, any renal function, and any previous urological history, urological surgery, and urinary symptoms. He was catheterized and the residual volume was 1.2 liter. What further information do you need? His current and baseline renal function, the color of the urine in the catheterization is clotted clots, blood, or pus. His creatinine was 300, baseline was 65 3 months ago. How will you manage him on the ward? So monitor early urine output. If diuresis and passes a large volume of urine more than 200 ml per hour, for 2 or more consecutive hours, I would commence intravenous fluid replacement 50 to 100% of the early urine output. Perform daily renal function test, monitoring for worsening renal failure and low potassium, daily assessment of the body weight, lying and standing blood pressure. What is the pathophysiology of post-obstructive diuresis? So from physiological perspective, post-obstructive diuresis occurs due to an accumulation of electrolyte fluid and waste products. Once the obstruction is relieved, these substances are then released. Pathological diuresis occurs due to the dysfunction of renal tubules and inappropriate salt and water handling by the kidney. So if his residual volume was 250 ml and his creatinine to 300 nanomole, how would you arrange him? So this is not a diagnosis of acute urinary retention until unless patient has a reduced bladder capacity due to the TB or previous radiotherapy. An urgent ultrasound scan is necessary as well as a digital examination to rule out pelvic malignancy and PSA level. The patient should remain catheterized to monitor the urine output with strict input-output fluid balance assessment and daily UNEs. Renal team input may also be necessary. Ultrasound scan showed bilateral head nephrosis. What next? This would depend on the results of the rectal examination and PSA. If these are normal, then non-contrast CT is essential to identify the cause and the level of the ureteric obstruction. If these are grossly abnormal, like PSA more than 100 and pathogenesis of the pathognomonic of the prostate cancer, then commence treatment for the prostate cancer and involve the urologist and the oncologist. You are unable to insert a ureteral catheter. How would you consent for a suprapubic catheter insertion? The nature of the procedure should be explained along with the risks and benefits of the suprapubic catheterization and alternative management options. The risk for suprapubic catheter insertion is a hemorrhage, including hematuria, abdominal bleeding, infection, including urinary and tract infection, pain, and injury to the abdominal organs, for example, bowel injury 2 to 3%. How would you perform a suprapubic catheter insertion? With reference to the guidelines, suprapubic catheter insertion, I would insert with ultrasound guidance. But initially, I will ensure that there is no contraindication of suprapubic catheter like carcinoma of the bladder, patient is an anticoagulant, abdominal wall sepsis, and the presence of subcutaneous vascular graft in the suprapubic region. It's called femorofemoral crossover graft. Suprapubic catheter insertion should be undertaken under the ultrasound guidance under local anesthesia to ideally with the Seldinger type SPC insertion. It's performed by infiltration of the skin of 2 finger braids above the pubic symphysis in the midline with local anesthesia, aspiration of the urine from the bladder. Confirm its position. Once a needle has been placed into the bladder, small skin incision is made, a guide wire is advanced, and the needle removed. The peel away sheath is inserted over the wire with a gentle rotating action. Resistance followed by give will be felt as the sheath passes through the bladder. Keeping the wire and the sheath in place, momentarily withdraw the introducer to allow the flow of urine and confirm that the sheath tip lies within the bladder. Swiftly remove the introducer and insert the catheter to its hub. Inflate the balloon and peel apart the sheath. Thank you.